This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Web-Based Education Series. Today's presentation is titled, On a Good Day, We Save a Smile. On a Great Day, We Save a Life. Doctors Barb McClatchie, DDS, and Eric Goulder, MD, FACC, are on a mission to enrich the quality of life for every patient. Their practice, Complete Health Dentistry of Columbus, employs a team of professionals specializing in general restorative dentistry and use research-based methods to ensure optimal oral and cardiovascular health. Dr. Eric Goulder is the founder of the Heart Attack and Stroke Prevention Center of Central Ohio in Worthington. After graduating from the Ohio State University College of Medicine, he worked for 20 years as an invasive and non-invasive cardiologist at Riverside Methodist Hospital in Columbus, followed by 14 years at Marietta Memorial Hospital. He then opened HASPC. In 2012, he was introduced to the Bale Doneen Method, which incorporates the most current research-based information, along with painless, non-invasive tests, including simple blood and genetic testing to help predict and prevent heart attacks and ischemic strokes. Brad and Amy are previous Practice Perfection presenters, and a recording of their webcast is available at our archives page. Eric is an accredited provider of the Bale Doneen Method. At HASPC, he looks for early asymptomatic arterial disease and evidence of arterial inflammation to stabilize the disease and thereby reduce the risk of cardiovascular events. Because dental infection and oral inflammation are key drivers of arterial disease, he has partnered with Dr. Barb McClatchie, DDS. Barb's practice, Complete Health Dentistry of Columbus, employs a team of professionals specializing in both general restorative dentistry and oral systemic research-based methods that ensure optimal oral and heart health. As an accredited provider of the Bale Doneen Method, she works in partnership with Eric. Together, they support other medical and dental professionals to help identify high-risk patients and prevent them from having heart attacks and strokes, as well as dementia. Barb is Pankey trained and is one of the first dentists in Ohio to be dental certified in Dale Bredesen's pre-code-recode protocol for reversing cognitive decline through dental medicine, which was the topic of last month's Practice Perfection webcast. She is a key opinion leader for the American Academy for Oral Systemic Health, PerioProtect, ProBiora Health, and serves on many advisory boards. As an attendee, you will learn to understand the value of medical-dental collaboration and how you, as healthcare providers, can impact your patient's total body health, the benefit that periodontal treatment has on medical inflammatory testing through actual case studies, the value of the carotid intima media thickness scan as it relates to periodontal therapy, and how a multifaceted approach to periodontal disease can impact total body inflammatory burden and decrease our patient's overall risk for a cardiovascular event. Attendance at today's event entitles you to apply to receive 1.5 hours of PACE-approved continuing education credit. Shortly following the presentation, you will receive information on how to apply to receive your CE. To be eligible, you will need to successfully complete a brief quiz, as well as note the following course number, which is MCC 072023. Again, that's MCC 072023. Having said that, if you're driving or it is otherwise inconvenient for you to jot down the code, I will add it in the chat shortly. And now it is my distinct pleasure to welcome to the Practice Perfection stage my friends, Drs. Barb McClatchie and Eric Goulder. Hello, friends.
Thanks, Danny. That was awesome. So, yeah, I'm as Danny mentioned, I'm a board certified cardiologist. I practiced what I would like to call standard of care medicine for over 35 years. And I was introduced to the Bale Doneen Method by my wife, Barb McClatchie, when she went to a presentation by Gary Cady, a practice consultant, and he talked about the oral systemic connection. She'd been very interested in that. And then one of her hygienists said, hey, there's a new organization forming. And so she went to the founding meeting, scientific session for the American Association for Oral Systemic Health, heard Brad, Bale, and Amy Doneen talk there, came back, told me like it was right up my alley. It was awesome. And I told her I didn't want to go to some silly dental meeting. And then she dragged me to it. And I said it was the best meeting I've ever been to. So I got in here sort of by my wife, who's a lot smarter than I am. And so I used, when I worked in the hospital, which I don't do anymore, now I practice exclusively preventive medicine. I did all the things, a lot of the things cardiologists do. I did heart catheterizations, we put in stents, and I did stress tests and put in pacemakers and read echocardiograms looking at the pumping function of the ventricles and the function of the valves and that sort of thing. My problem was that I was getting frustrated because I would see this lady come in, and she didn't have to be a lady and she doesn't have to be old, but she'd come in having bad chest pain or a heart attack. We'd whip her on up to the cath lab, take pictures, see what's going on in there and fix her with a stent or send her off to bypass, whatever she needed. And then 3, 4, 5 years later, here she comes again. She's having another event. And it was like we were putting Band-Aids on the 30,000 miles of arteries that you have, instead of really looking for what's driving this problem. I mean, so often we would sit around, 3 or 4 of us cardiologists looking at films and say, oh yeah, we need a stent here. And then somebody said, well, wasn't Fred just in here 9 months ago getting a stent? What's going on here? And we say, throw up our hands. I don't know, he's just got aggressive arterial disease. We really weren't, we didn't have the ability at that point in time to figure out what was driving all this. And so because of that, our mission now is knocking cardiovascular disease out of the top spot as the #1 killer in this country, where it's been for 125 years. And so patients ask me a lot, when I do a CT scan on them or I find evidence of early arterial disease, and they say, well, isn't that normal? I say, no, it's not normal. It's very common, but it's definitely not normal. And if you think about your own family and circle of friends, I'm pretty sure that we've all been touched by arterial disease in one fashion or another. I mean, someone that has had a heart attack, bypass surgery, stents, stroke, sudden cardiac death. I know my family's been that way. And so by the time we reach 65 in this country, 80% of us have arterial disease. 50% of the time, the presentation of that arterial disease is when you have a heart attack, a stroke, or drop dead. Half the time. The lucky people are the ones who are having trouble with chest pain or shortness of breath or fatigue, and they go see their doctor and get it figured out. But the most likely diagnosis to be on your death certificate is cardiovascular disease. Every 40 seconds, somebody in this country will have a heart attack. Every 40 seconds, somebody has a stroke. Every minute, somebody's going to die from a heart attack. Every 3.5 minutes, somebody dies from a stroke. Stroke is the leading cause of disability in this country, and 2,400 people die from cardiovascular disease every day in this country. And while it sounds like a big number, let me put it in perspective a little bit better for you. If you've ever been to DC and seen the Vietnam Memorial Wall, and this is really poignant for me because that's when I'm old. This is when I was going to school. The Vietnam War was, I was in college, and there's 58,000 Americans on that wall. Every 3.5 weeks, 58,000 more Americans die from cardiovascular disease. We have a Vietnam's war worth of death, and then we do it again the next 3.5 weeks. So cardiovascular disease has been the leading cause of death since 1900. It's been gradually going up, and we know that it's been getting worse since World War I. The government, in their wisdom, gave all the soldiers, doughboys back then, gave them all free cigarettes. They did it again in World War II. If you look at a graph for lung cancer, about 20 years after World War I, it starts accelerating, looking like a lot like this curve. The Surgeon General's report came out in 1964 saying that smoking is related to cardiovascular disease. 1970, Cleveland Clinic does the first bypass operation, balloon angio, and now you see, okay, now we're starting to get a handle on it. Okay, the rate's been rising. Now it's starting to come down a little bit. Balloon angioplasty comes out in the early 80s. Stents follow shortly thereafter. We're really getting a handle on this. My problem with this curve is what the heck is going on now? All of a sudden, it's heading back up, and I think it's related to the fact that this younger generation or two of people have been raised on fast food, lifestyle that's not ideal for preventing disease. And so if you look at the statistics published by the CDC, that if we look at obesity on this map of the country and diabetes over here, you see that, yeah, there was a fair amount of diabetes and obesity back in 1994, but watch what's happened over the next 20 years. As we just click through these maps really quickly, we're getting sicker and sicker every year. And so if you compare those two maps, you can see there's been a huge increase, almost a doubling in diabetes and obesity in this country. And if you look at a map of where heart disease deaths occur, it pretty much mimics the map of where there's all this diabetes and obesity. Those are two really big risk factors for this problem. And so, you know, I said that I practiced standard of care medicine for 35 years. And so what is standard of care medicine? Well, standard of care medicine is practicing medicine by the guidelines handed down for cardiology, handed down by the American Heart Association and the American College of Cardiology. And they come out with these guidelines every year. They're updating guidelines, and there's hundreds of them. They tell me how I should take care of high blood pressure, cholesterol problems, heart attacks, strokes, diabetes, smoking, congestive heart failure, rhythm problems, anything you can think of in cardiology, there are guidelines for it. So if you go to your standard of care doctor and say, okay, what's my risk for having a heart attack or stroke over the next 10 years? And what they're going to do is they're going to get out their cell phone and bring up their risk calculator app, because we've all got it, and calculate your risk. And your risk is going to be based on this Framingham study started in 1948. Framingham's a little town in central Massachusetts. They sent doctors from Boston over there in 1948, and they did a history, physical, blood work, EKG on everybody in town and just followed them. And this is the study where we found out that people with high blood pressure are having more heart attacks. People with high cholesterol are having more heart attacks. This is the study where they found out that smoking is causing more heart attacks. Back in the day when they were, you know, doctors had full page ads in Look and Life magazine tell you which was the best cigarette for you. So this 10-year risk estimation is based on your age, gender, your total cholesterol, your good cholesterol, tobacco use, systolic blood pressure, and are you taking a blood pressure medicine or not? And so you factor all those in there and you come up with a number. And so if you're a 50-year-old guy or a 55-year-old woman, and you've got a normal blood pressure and normal cholesterol and normal good cholesterol, and you're not a smoker, you're not taking any blood pressure medications, your risk for having a heart attack or stroke is 4.5% for a 50-year-old man or 55-year-old woman. And the problem with that risk score is it's not very accurate. So what it means is if I took 100 men or women just like you with your same age and cholesterol numbers and blood pressure and smoking history and put you all in a room and said I'll be back in 10 years, okay? 4 or 5 people in that room are going to have a heart attack or stroke. But I can't tell you if it's going to be you or it's going to be these other people. And so the risk, so that's why, you know, interpolating this data down to you as an individual doesn't work. We need to know a lot more about you. And the other reason we know it doesn't work is because this Dr. Acosta did this great retrospective study. He took 222 men and women coming in having a heart attack at a young age. Young age, premature heart attack means the average age for a guy in our country for a heart attack is 65. The men in this study were under 55. The average age for a woman for a heart attack is 72. The women in this study were under 65. And he's got them lying on the table in the emergency room. He's got everything he needs to calculate their risk score: age, gender, blood pressure, cholesterol, all that stuff. Calculates their risk score because he wants to know, is this risk score going to prove to me that these people coming in at a young age were at high risk? What did he find? He missed 82% of the women and 66% of the men as being at high risk. So the risk scores aren't very helpful. And so, you know, the question is, how does the standard of care fail us? Okay, and so one example is Tim Russert. I don't know how many of you are old enough to remember Tim Russert. He was on Meet the Press on NBC on Sunday mornings, a political talk show. He went to see his doctor. He was middle-aged. He went to see his doctor, and he was getting standard of care treatment. He was on a statin for his high cholesterol. He was on his blood pressure medicine. He was on a baby aspirin. All his medicines were right. All his numbers were right at goal, and his doctor said, you know, Tim, you're getting to be that age, 58, where guys start to have trouble with heart problems. We should, you know, we should do a stress test on you and make sure you're okay. So they sent him, he agreed, they sent him down the street to the local hospital. They did a cardiolite, a radionuclear stress test on him. He passed it with flying colors. What happened to Tim Russert? He dropped dead of a heart attack walking down the NBC studio hallways 8 weeks later, because he had a mild blockage that isn't going to be detected by a stress test. Another good example of this is John Warner. John Warner is a past president of the American Heart Association. About 2017 or so, when he was president, he was at the annual meeting. He gives the keynote address there. He's glad handing people, talking with friends and meeting with people and all day long. This is after he'd already been to the gym and worked out in the morning on a bike. And then he comes back to his hotel room, which was in the same hotel with the meeting, walks in the door and drops dead. Fortunately, his teenage daughter and son were there. His daughter had been instructed on non-breathing CPR. She starts doing CPR on her dad, if you can imagine that situation, how horrible, and sends her brother running up and down the halls yelling for a cardiologist, because there were hundreds of them there in that hotel. And so a pediatric interventional cardiologist and her nurse practitioner came running in, took over CPR, got the squad there, got him off to the hospital. He got stented and survived. And the point of this whole story is he's giving interviews the next day, okay, saying, oh, I knew, this is a huge ironic story, right? The president of the American Heart Association drops dead of a heart attack at the meeting. And so he's giving interviews to NBC, CBS, CNN, everybody and he said he knew that he was preordained to have a heart attack at a young age, because when his first child was born, there were no men from his side of the family over the age of 50 in the room to welcome her. And so, he was 52 years old. What he didn't know was that if you follow a Bale Doneen approach, a preventive approach to arterial disease based on looking for disease when it's asymptomatic and treating it by stopping the inflammatory root causes, that we can prevent this stuff. So if you're having trouble, say you're having chest discomfort, shortness of breath, fatigue, and you go see your doctor and say, okay, I've got all this stuff going on, what's your physician probably going to say? He's going to say, well, let's look and see if you've got any coronary disease. We'll start off with a stress test, or maybe even a radionuclear stress test or a stress echocardiogram. And all three of these depend upon the flow through the artery. If the flow through the artery is normal, the stress test is going to be normal. So what does that flow look like? Well, most of us would think that here on the x-axis, we've got blockage getting worse and worse and worse until the artery is totally blocked. Up here on the y-axis, we've got flow. And most of us would think it would look like this. No blockage, 100% normal flow, totally blocked, no flow. Blockage gets worse and worse and worse. The flow gets worse and worse and worse until it's totally blocked. And that's not what happens. What happens is the flow through the coronary arteries is exactly the same as the flow through any pipe. Just pure physics. It stays pretty much normal until you get to be about 65 to 70% blocked, and then it plummets. And you sort of knew this, because if you go out back to water the plants and you can't find the nozzle, you know how to fix that problem, right? You just cover up the opening of the hose. And if you cover up by 30 or 40%, nothing's happening. But if you cover up 2/3 or 3/4, now the flow has decreased, the water accelerates across the blockage, which is your thumb, and shoots way out, and you can water what you want to water. And so Dean Berman, one of the gurus who helped develop the radionuclear stress test 20 years ago, said that patients who have normal imaging stress tests frequently have extensive atherosclerosis. What did he mean by that? Because to me, as a cardiologist, that was a head slap. Okay, what he meant was that you can have 20, 30, 40, even 50, 60% blockages in your arteries, and your stress test is going to be normal because the flow's normal. And what happens when you take a stress test and you comes back normal? You get a pat on the back. George, you're fine. Don't worry about it. It's not your heart, okay? Because we confuse normal stress tests with you're okay, you don't have any problems. All a stress test can tell us is if you've got a blockage of 70% or more, a blockage so bad that you need to have a stent or a bypass to fix it. So that begs the next question. How bad are the blockages that cause heart attacks? Well, if we had a time machine and we could take everybody who's having a heart attack today, in case you don't know, this movie is The Time Machine by Orson Welles from about 1960 something. And we could we take all these people and go back to yesterday or the day before and do a stress test on them. What would we find? what we would find would be that 14% of those stress tests would be abnormal, and hopefully those people would get a heart cath and a standard bypass. 86% of the time, the stress test a day or two before the heart attack happens is going to be normal, because the blockage that's going to cause that heart attack 86% of the time is less than 65 to 70%. And actually 68% of the time it's less than 50%. So it's the milder blockages, the ones that aren't going to show up on the stress test, that end up causing the heart attacks. So to tell you what your personal risk is, obviously we need to know a lot more about you. Okay, do you have inflammation in the walls of the arteries? What are your lipids like? Not just your cholesterol, good cholesterol, total cholesterol, but what's your ApoB? That's a protein on the outside of all the bad cholesterol. That's the best marker for who's going to get in trouble with their cholesterol problem. Do you have lipoprotein little a? This is something that 10 years ago most doctors didn't look at, and now they're starting to. It's a bad cholesterol particle with an extra protein on the outside. It's genetically driven, and it doesn't respond to statins. It doesn't respond to lifestyle. You can be a vegan and run 5 miles a day, and your LP little a won't budge. Your LDL will come down, but your LP little a won't come down. Are you insulin resistant or diabetic? Standard of care medicine is pretty good at picking up diabetics. They're not so good at picking up insulin resistance. And insulin resistance is something that's present 2/3 of the time in people who have a heart attack, and it's been there for 10 to 15 years. What are your genetics like? Are they putting you at more risk? And based on your genetics, we can make some recommendations for lifestyle changes, because the same lifestyle is not the right lifestyle for everybody. Do you actually have arterial disease? That's a huge question, because standard of care most of the time doesn't look for that. Do you have any dental infections? This is clearly one that standard of care medicine is clueless about. If you ask most doctors, they'll say, oh yeah, I'm aware of that, but they really don't do anything about it. If they've got people who are at risk for arterial disease problems, say you've got people with high blood pressure, high cholesterol, do they ask the question, when was the last time you saw your dentist? Did you ever have bleeding gums? No, they don't ask that kind of thing. So the question is, where do you want to be 20 years from now or 30 years from now, depending upon how old you are? And we all want to be up here, and I don't care if you play golf, but you want the Joe Cool shades, you want all your marbles, you want to be enjoying life, enjoying all those milestones with your kids and grandchildren. And so you have to follow the right pathway. That right pathway means doing something for mental health, and I don't care whether it's prayer, meditation, mindfulness therapy, yoga, walking in the woods, listening to music, whatever takes your mind off your day-to-day stresses. Eating a healthy diet, getting some exercise routinely, getting enough sleep, and making sure that you're getting good quality of sleep, because obstructive sleep apnea is one of the most underdiagnosed problems in the country. And taking care of your oral health, as Barb's going to talk about a lot more in a minute, because we know that there's 5 high-risk bacteria that actually help drive arterial disease. If we do all that stuff, it revs up a whole bunch of genes that keeps us young and healthy. On the other hand, you can, stick your head in the sand, follow the wrong pathway, have pre-diabetes and not know it, not looking for it, a little bit of pink in the sink's not bothering you, your snoring doesn't bother you, not eating the right diet, not exercising, all that revs up a whole bunch of genes that gets us where none of us want to be. And so how does this preventive approach work, this Bale Doneen approach work? Well, number one, we look to see if you actually have arterial disease, because that's something the standard of care doesn't do. We check your arteries to see if there's inflammation going on. We look for all the known causes of arterial inflammation so that we can control those things optimally and turn off that whole inflammatory process. And then we just watch the arteries get better. Your body, if we get the inflammation and the cholesterol out of the plaque, your body's going to heal those plaques. And so this is a Bale Doneen cartoon showing that these are all the things we know of that drive inflammation, taking your arteries from being normal to having cholesterol build up in the lining, with cholesterol and inflammation building up in the lining, to having plaque develop, having that plaque get bigger and finally rupture. And if we get all these things under control optimally, we turn off the inflammation process and everything goes back the other way. So here's what a normal artery looks like. There's a central lumen here where the blood's coming right out at us. There's a 1 cell thick lining layer here called the endothelium. This is actually it separates the blood flow from the rest of the arterial wall. And for a long time, that's all we thought it did, but it's actually the largest metabolically active organ in our body. If we took all the endothelium out of all 30,000 miles of arteries in our body and laid it out on a tennis court, it would cover 5 or 6 tennis courts. Right under the endothelium is the intima. this dark pink area right here, and this is where all the bad stuff happens in the artery. There's a muscle layer for regulation of blood flow, and there's the outer wall, which is just connective tissue and elastic tissue. But this is where all the bad stuff happens in the intima, and that's what can happen in there. So this is a really bad blockage. This is about an 85% blockage. This is all that's left of the opening for the blood flow. This person's probably okay sitting around not doing anything. If they get up and walk too quickly, they're probably getting chest discomfort or shortness of breath. But this blockage is all full of calcification, scarring, fibrosis. There's no cholesterol left in here. There's no inflammation left in here. This is a stable old blockage, and there's a wall of calcification here. It's probably not going to rupture and cause trouble. This guy, on the other hand, a much milder blockage, maybe 20-25% blocked, is all filled with cholesterol, and your body's reaction to that cholesterol getting in there, which is inflammation. And it's just covered by this thin fibrous cap, and that's what can rupture and cause the heart attack. And so, this whole process takes decades. If you look at the artery, if you do a heart cath on somebody in this stage, this first 40, 50, 60 years of development, the arteries look normal, okay? It's not until the plaque starts to get big enough that it starts poking into the lumen that we can pick it up on a heart cath. But here, we can't see anything's going on. Okay, and so these plaques are very similar to the pimples you used to get when you were a kid, or if you get a splinter in your finger and it's going to fester and it gets all red around there and pus and it finally works its way out. They're all an inflammatory response to an insult, whether it's the bacterial infection that causes the pimple, or it's the wound or in the splinter, or whether it's the cholesterol and the inflammation in your arteries. They all continue to grow and they can all rupture. And so I'm sure you've all seen this.
See if you can guess what I am now. I'm a zit. Get it?
And that's a heart attack. And that's a heart attack. This is the plaque. It was all soft inflamed plaque. That thin fibrous cap over the plaque ruptures, and your body wants to heal that with a blood clot, just like when you nick yourself shaving, working in the kitchen, working in the yard, you get a scratch, it's going to bleed, you're going to get a scab, it's going to heal with a scar. Your body wants to heal this torn lining just the same way. The trouble is your arteries aren't very big. Your coronary arteries, at the very beginning, the left anterior descending artery, the widowmaker, may only be 2.5 to 3 millimeters in diameter. By the midpoint, it may only be 1 3/4, 2 millimeters in diameter. Not a lot of room in there for a blood clot to form without causing serious trouble. And so the question is then, if we look at the lumen and it looks great here, how do we look at the wall of the artery instead? Because on a scan, this is going to look different. Here's a heart cath, and this is an absolutely normal looking artery. Here's someone coming in with the same artery, the right coronary artery, with a 98% blockage right here, which got stented. But the problem is that there's all this other stuff. If you look all up and down this artery, there's hardly a normal section to this artery. There's plaque everywhere. And so what if I told you there was a simple non-invasive test that could catch 98.6% of heart attacks and strokes before they occurred? There's a way we can look at the arteries and say, hey, you're at high risk for having an event. We should do something now before you become a statistic. And that test is the carotid intima media thickness test. It's an ultrasound test. It takes 15 minutes to do. It scans the carotid arteries in your neck. Patients don't have to disrobe for it. It's painless. We could do it every day and it wouldn't be a problem. And so a heart attack or stroke's not a surprise if you know what to look for. And if we know we can look in the carotids and see if you've got disease, then we can say we got to do something to prevent it. And that's the point. It's all preventable. And so this is the other way we can look to see if you've got arterial disease non-invasively. We can do a coronary artery calcification score on you. It's a CT scan, a CAT scan of the chest. On this scan, this guy is lying on his back. There's the table. Here's this. His feet are where we are. His head's behind the screen. Here's the spine, breastbone up here, rib, scapula over here. This is the descending aorta in the chest. So the aorta, as you know, leaves the heart, heads north, gives rise to the arteries of the arms and the head and neck. And then it makes a U-turn. And heads south. And this is the aorta heading south in the chest. And there's a couple of white flecks in there. And those white flecks are evidence of calcification. Here's the widowmaker down the front wall of the heart, the left anterior descending, chock full of calcification. Here's the circumflex artery going to the back wall, chock full of calcification. Whenever we see calcification, whether it's a little bit or a lot, it says there's arterial disease. The only way you get calcification in the arteries is if you've got plaque. The problem with this test is it can only pick up this blockage. It doesn't have to be anywhere near this severe, but it can only pick up calcification. It's not going to see this soft inflamed blockage. There's no calcification in it. And so you can have a coronary artery calcification score of 0, be full of this stuff, and still be at high risk. And so the CIMT scan shows us what the lining of the artery looks like. It shows us if there's plaque or not. It tells us if the plaque is all soft and inflamed, all this fuzzy stuff up here, this fuzzy stuff up here, or is there some calcification like this brighter stuff down here and this stuff here and here. And that says that artery is trying to heal. So it turns out this is a great way to follow the disease process, because if we start out with an increased lining thickness, and we're going to call that an increased arterial age, and I'll show you that in a second, or we start out with plaque and we say, well, you've got a little bit of calcification and we're doing everything right, getting the inflammation under control, and the cholesterol down, and you're following the right lifestyle and getting your exercise and getting all the other root causes taken care of, your sleep and your periodontal disease, endodontitis, all that other stuff taken care of, we see this lining layer start to get thinner and thinner. We see the plaque start to develop more and more calcification. That plaque may not go away, and in most likelihood it's not going to go away, but it's going to stabilize. And the key point here is we can all live with atherosclerotic plaque. We just can't live with soft inflamed plaque. Once we get it all stabilized and calcified, it's not going to rupture. So I don't care if you've got a 30-40% blockage, as long as it's stabilized and calcified. So who needs a CIMT scan? Well, I think everybody over the age of 40 ought to have it by that time in their life, at least once. And if it's normal, then okay, maybe wait 5 years and do it again. If you've got a problem, then we need to get on it. Anybody who's got a family history of heart attacks, bypass surgery, strokes, stents needs to get a CIMT done at a younger age. Anybody with one or more risk factors for arterial disease, high blood pressure, diabetes, cholesterol problems, smoking, sedentary lifestyle, all those things ought to get a CIMT done. And certainly anybody who's got evidence of arterial disease on a cone beam or on a panoramic x-ray ought to have a CIMT done to see what's going on. So, and then who else needs a CIMT scan? Well, this is sort of, Amy Doneen calls this a party game. I don't know if it's that, but there are some physical signs that we can look at and say, oh yeah, you're at increased risk. So Frank's sign is this transverse crease in the earlobe. And you can start looking, Barb and I do this all the time. We're watching a movie on TV and, oh, that actor's got a transverse, he's at risk. He's got a 78% increased risk, not a 78% risk, but a 78% increased risk of having a heart attack or a stroke. Male pattern baldness, frontal male pattern baldness, on the crown, male pattern baldness also increases risk. Xanthomas, those little bumps on the inner part of the eyelid, or Fordyce granules in the cheeks, are all markers for high cholesterol and risk for heart attacks. And so we know that inflammation drives the arterial disease process. It's inflammation that drives almost all chronic disease now. And so what we want to know is, are your arteries inflamed? And so we've got a half a dozen really good, relatively inexpensive tests, very common tests that we do on all our patients to say, what's going on with your arteries? F2 isoprostane is looking at total body oxidative stress. Are you getting enough antioxidants from diet and exercise to combat the fact that we're all oxidizing, all rusting all the time while we're living? HSCRP is the one that most standard of care physicians know about. It's related to, it's been proven to show that when it's elevated, there's increased risk of having cardiovascular disease. It denotes inflammation of the endothelium. Fibrinogen is actually part of the blood clotting mechanism, but when there's inflammation around, your liver makes more of it, and it's a pretty generalized marker of inflammation. Microalbumin creatinine ratio is a very sensitive marker for endothelial inflammation, because it shows us that in your kidneys, your capillaries are allowing albumin to leak into your urine. That's a great big protein molecule and should not be able to get into your urine. So when that's elevated, that says you've got problems. Very specifically, inflammation of the endothelium. LP-PLA2 is an enzyme that travels with the LDL particle, gets into the lining of the blood vessel, into the intima, and gets oxidized, creates cytokines that call over white blood cells, monocytes. They come in, try to fix things, but they can't. All they can do is gobble up the oxidized LDL, turn into plaque. So this guy says when it's elevated, it says you are actively having an ongoing atherosclerotic process. And then myeloperoxidase we always look at because it becomes elevated, particularly with root canal lesions. It comes from white blood cells. And as you know, half those root canal lesions could be asymptomatic. So you can be feeling fine, have too much of this myeloperoxidase floating around in your system. And that same enzyme, which is designed to kill bacteria, can chew on that thin fibrous cap over plaque, making them more likely to rupture. So we follow these things quarterly to make sure that my patients are all have their arterial inflammation under control and allowing the arterial disease to heal. And I can't get out of this slide. There we go. Okay, so we want to know if they're inflamed, and if they are inflamed, why are they inflamed? These root causes are the whys for the inflammation. We want to go look for all this stuff and get all these things under control: low vitamin D and insulin resistance and diabetes and periodontal disease, endodontic disease, sleep, disturbed breathing, sleep breathing, obviously cholesterol, high blood pressure. Get all that stuff under control, and everything goes back the other way. And so by doing that, we know that heart attacks are optional. And Amy Doneen and Brad Bale have proven this with studies that they've done and studies that they've done in conjunction with Johns Hopkins, that this whole approach stabilizes plaque and prevents events. The bad news is that most doctors aren't looking in the right places or with the right test for arterial disease, and they aren't using that state-of-the-art CIMT imaging, blood and genetic testing to see whether their patients are at risk and how high their risk is. And so you can find out if you're at moderate or high risk for a heart attack or stroke by getting a CIMT. Again, it's simple. It's 15 minutes. It's painless. It's inexpensive. It's, you could do it every day. It's a great way to follow your arteries, make sure you're not developing a risk for a heart attack or stroke. And so this is what that CIMT looks like. So on this scan, your heart's going to be down this way. Here comes the common carotid artery up the neck, heads up this way. Right here, this line is where the artery turns into the carotid bulb. And then it's going to branch right here into the internal carotid artery, which I care about a lot because it goes right up your brain. The external carotid artery, I don't care about so much because, it just goes to the muscles of your face that you guys all care about, but it doesn't, but I don't care about it so much. And so what we're looking for on this scan is two things. Number one is how thick is your lining layer? And so we're going to come down into the common carotid artery here, draw this box 1 centimeter long, and measure the thickness of this lining layer at 100 points in here. And so you can see that the artery, if I get a heart cath on this person, injected dye in this artery, it would look totally normal. I wouldn't see these little lumps and bumps, but we can measure these and average all this from 100 points. And there's actually 6 boxes like this that we use on the CIMT scan. So 600 data points all averaged together is a very accurate number for the lining thickness. And we know how thick the lining should be on everybody from ages 5 to 80. It's a little thicker in men than women. It gets thicker as we get older. And then if you follow that lining layer out here into the carotid bulb, it gets even thicker out here. So this is an example of some plaque in the carotid bulb. Definition of plaque being an area of thickening of 1.3 millimeters or more. And so on this scan, if we look at this scan, you can see that on this lady, she's 65 years old, and her lining thickness is 0.88 millimeters. Okay, and so to figure out what that means, because that doesn't mean much to any of us, we're going to look at this graph where we've got thousands of people that we've done scans on. And so from ages 5 to 80, we know what the mean thickness of that lining should be. And so we're going to follow that along on that line until, for a woman that is in the pink line, until it hits that pink line, drop that down. So we get like 81. She's greater than 80. So she's got arteries that are 15, 16 years older than she is. And then the next question we've got is, do you have any plaque? Yes, she does. She's got 4.9 millimeters of plaque. Where does she have it? She's got it in the internal carotid, left carotid bulb, internal right internal carotid, left carotid bulb, left internal carotid artery, and almost plaque in the right carotid bulb, 1.2. So if this was 1.3, she'd have 6.1 millimeters of plaque just by getting 1/10 of a millimeter thicker. But you can see that the difference between where she is and where she should be is only like 1/10 of a millimeter. So it's not something you're going to see on a CT scan. Okay, and so what we do know is that people who have periodontal disease are at increased risk, doubles the risk for heart attacks, triples the risk for strokes, quadruples the risk for dementia, low birth weight babies, early death, shave 6 to 10 years off your life. And so that's why I'm working with a dentist who understands this preventive approach, this Bale Doneen approach, because while I can take care of most of this stuff, I don't do sleep, and I don't make sleep appliances. I don't know anything about well, I know more than I used to because I've been working with Barb for a while, but I don't know much about periodontal disease because they didn't teach me anything in medical school, and I don't know anything about endodontic disease. They didn't teach me anything about that in medical school. So that's why if you're a Bale Doneen physician, you need to be working with a Bale Doneen trained or oral systemically minded dentist who can help me out with this stuff. And so, yeah, and you guys are on the cutting edge. So, you know, you do these Panorex x-rays and say, okay, these teeth look okay. Yeah, you got fillings here and here. And, you know, I don't see any periapical abscesses. That's all looking good. But you know what? There's a lot more that goes on here. So what we do with all of we do cone beams in our office because they're more sensitive at picking up periapical abscesses than digital x-rays. And we send them off to get read. We send them to beam readers to get read by a dental radiologist because, you know, you guys look at the teeth and you don't see that, oh my gosh, look at that. There's some calcification in that carotid artery over there. So you got to look at the whole thing. And when you see that, now you say, oh my God, you've got arterial disease. You're at risk of a heart attack or stroke. And if you've got high blood pressure and high cholesterol, you better be talking to your doctor. And so we know by work done by doctors Bale and Doneen and David Vigorist that there are 5 high-risk bacteria that help drive this whole arterial disease process: AA, PG, TF, TD, and FN. And Barb's going to talk more about that. But we know from this awesome study that oral pathogens help play a huge role in driving arterial disease and heart attacks. And so in this study, they took 100 people having a heart attack. And when you come in having a heart attack, you know, you get whipped off to the cath lab. We take pictures, see what's going on. And just before we put in the stent, we suck as much of that blood clot out of there as we can because we don't want to be shoving stuff downstream, blocking up little tiny vessels that we can't fix and that sort of stuff. So we suck that clot out of there. And when they looked at this blood clot with polymerase chain reaction testing, like they look at saliva testing for bacteria, they found oral viridin streptococci, root canal pathogens in 78% of the blood clots, and periodontal pathogens, AA, PG, TF, TD, FN, in 35% of the blood clots. And so the question is, and then there were no bacteria in the arterial blood. So the question is, how did those bacteria get in that blood clot? Well, they were in the plaque, and then the plaque ruptured, and then that person made a blood clot over that plaque to try and heal, and that's how the bacteria got into the blood clot. So 50% of heart attacks are triggered by oral pathogens. So that's why we do saliva testing in our office. We want to know what's going on in your mouth because this drives the arterial disease process tremendously. And so real quickly, bottom line here, first step in prevention is to look and see if you've got mild asymptomatic arterial disease. If you've got arterial disease, we want to know if there's inflammation going on because that's what drives everything. And if you've got arterial disease, we need to look for those root causes. If we treat those root causes optimally, it turns off the inflammatory process. And without the inflammation, your body's going to heal itself. That whole process is going to slow down, it's going to stop, and even reverse the progression. And high-risk periodontal pathogens play a major role in the development and the progression of arterial disease. And you can take the first step for you or for your patients by getting CIMTs done. We do them in our office. You can contact Cardio Risk is a great company that they're out in Utah that does CIMTs. If you're interested in this and you want to have them come out to your office, if you collect a bunch of patients, they will come out for a day and do CIMTs on your patients at your office so that you can find out who's at risk and how much risk they're at. And oral infections play a major role in the development of that arterial disease process. Treating those infections can reduce the arterial inflammation. You guys, dentists, hygienists, dental assistants are on the front lines in preventing cardiac events, can save lives, not just smiles. And I can't do my job without you. And now that's enough of my talking at you. I'm going to give this over to Barb, and she's going to tell you all about the dental component and how we work together.
Thank you, Eric. Welcome, Barb. That was great.
Thank you. Well, good evening, colleagues. I'm going to speak to you a little bit more about the oral systemic approach to dentistry. And I really don't know my audience this evening and how familiar you are with the oral systemic approach. So there's going to be some fairly elementary concepts that I'm going to talk about today, but I appreciate you devoting your evening of listening to possibly something that might be very new to you, and it's just something that could change both you and your patients' lives. So, you know, I hope you approach this evening with a open, different mindset, because we're going to talk about medical and dental collaboration. And it is a frustrating journey. I am lucky to be practicing with a physician that is like-minded, but our goal is to really help get the message out so there are more people that do start network and collaborate together. But I'm going to give you a little bit of info and tools on, you know, what it might look like in your practice if you were to implement some of these systems into your practice. And we'll kind of just share what's working for us. But if the standard of care providers stay in their own lane, we're not going to get anywhere. So it's really time that we need to start looking at our patients a little bit differently. We know that with collaborating between specialists, that we're going to get more knowledge and really be better advocates for our patients. So I'm going to show you what gives us our passion. I'm going to introduce you to Tracy. And Tracy is a patient of mine that is now a patient of Eric's. And he's going to tell you his story.
I got an ear infection in May of 2019 and had tubes put in my ears. And July, I wasn't getting any better. So I started acupuncture. I was a smoker, and the middle of September is when I woke up one morning and my hands and my knees were swollen. And I went to the doctor, and they diagnosed me with rheumatoid arthritis. So from there out, I was on methotrexate and prednisone and several other pills trying to get this settled down and straightened out. And along the way, I was not getting any better. And I told my RA doctor that I was not getting any better. So long about April or May of 2020, I told him we needed to change my medicine or I was going to find another doctor. So he switched my medicine to Humira and methotrexate, and I started feeling a little bit better, but nothing like I was before I come down with all this. So my daughters and son decided that they wanted me to try biofeedback. So I went the latter part of May to her, and it's where she diagnosed me with a bad infection in my gums and my teeth and suggested that I would come to Dr. McClatchie. They did a saliva bacteria test and some blood tests and found out that my mouth was completely full of infection. And Dr. McClatchie's hygienist, Becky, spent 4.5 hours cleaning my teeth. And within 48 hours of that, I started feeling better. My joints didn't hurt as bad. And I'm on the road to recovery. That simple test told them that my mouth was full of infection. Think about your mouth as the gateway to your health, because it is. Since Becky has done 2 cleanings and blood tests, and my infection went way down. My health a year ago. Oh my God. This is the worst part of it. Oh, my health a year ago, March, was declining. Before I come in here, I wasn't sure what was going to happen. I was bedridden, walking with a cane. I couldn't get up out of a chair myself. I had lost 44 pounds in a matter of about 6 or 7 months. And once I went to biofeedback, and she referred me to Dr. McClatchie, and we got my mouth straightened out, got the infection settled down. I have turned around, and I'm probably 75% of where I was before I got sick in 2018. I truly believe if I hadn't found Dr. McClatchie, that I would be bedridden, or even worse, not here today. She has done me right. Just go different doctors and get all the answers, not just one. Oh boy. If you have rheumatoid arthritis, please go to your dentist or a dentist, or find a dentist that does the saliva bacteria test, because I'm sure there's more than just me out there, because I can remember the second time I walked into the rheumatoid arthritis doctor. I seen all these people with canes and couldn't get out of their chairs and stuff, and I looked at my daughter and told her that wasn't going to be me. And it didn't. You got to go forward and try other things to see if the rheumatoid arthritis is your only problem. That's what I did. Well, I mean, normally this isn't me. I don't get emotional, but this here has taught me a lot about life and about health. Since I walked into this office, it has been nothing but great.
So I really would like to acknowledge Tracy for his vulnerability, for him sharing his emotional journey with all of us. It took courage to challenge the standard of care approach that he had, and he has actually become a voice for others on how oral health has greatly affected his systemic health. He's actually been an advocate and been doing interviews with medical and dental journals to share his story, hoping to get his message out there, and featured in Bale Doneen newsletters. And so I just want you to realize the impact that we as dental professionals can really have on patients. Okay, so our vision, other than knocking cardiovascular disease off as the #1 killer, is to really merge medicine and dentistry into one healthcare system that makes us better advocates for our patients. And my purpose here tonight is really to empower you all as dental colleagues and to impress that your work really does matter. I'm assuming that most of you are fairly new to the oral systemic concept, so be open, and you can have many Tracies in your office today. But along with my hygiene team, I am a Bale Doneen trained dentist, and I understand how chronic inflammation in the mouth is directly related to many other diseases. And it truly does take a great team of hygienists. So any hygienists that are out in the audience, you are my hero, because it's really the hygienist that is focusing on the oral systemic part of in the dental team. You're the ones who are doing the saliva testing, reviewing the health histories, making the connection, diagnosing, introducing what periodontal disease is and the treatment. So it does take a powerful team. And as you all know, 80% of Americans over the age of 35 has some form of periodontal disease. And the deeper the pockets are where the anaerobic bacteria live, which is what we are testing for, the 5 high-risk bacteria. And that bacteria enters the bleeding gums, and there it starts the inflammatory process and travels through the body. So this is a nice little a little picture that depicts that the bleeding enters into the bloodstream. And so what we do know is what happens in your mouth does not stay in your mouth. The mouth talks to the body and the body talks to the mouth. This is an infographic from the American Academy of Oral Systemic Health, which we are members because we do appreciate like-minded community members. And that's where we go to get our energy and fuel when we start talking to like-minded professionals. And we do know that there are 57 diseases that are associated with periodontal disease. We have many things like this in our practice to help educate our patients. And as Eric told us earlier, that when they dissected the clot from the carotid artery, they did find AAPG-TFFN, all these oral pathogens. So we do know that what happens in the mouth does travel through the body. What I do want to point out is the top 3, AAPG and TF, are root plane resistance. So just because you're doing root plane and using the ultrasonic and breaking up the biofilm and the clots, you're not killing this bacteria. So that's why we at times will be using antibiotics to help with high-risk patients to help kill this bacteria so that it doesn't multiply and continue to form more biofilm. So these dangerous bacteria continue to replicate in the pocket if they're not disrupted frequently, which then causes the inflammation and the bacteria to damage the tissue and the bone. And we've all seen tissue looking like this. So what I want you to do is really look at periodontal disease with a new mindset, that it really is a medical condition, but it does have a dental solution. So think about this, that our hygienists are not just removing deposits and stains, they actually are dealing with potentially very dangerous bacteria that are accessible to the body through the bleeding pockets. And it is like placing your patients at risk, even by doing root planing if you don't know what you're working with. Okay, we understand that it takes bacteria and a host and an inflammatory response for there to be periodontal disease. And by the time we see the disease, it depends on the host's defense on whether it's going to break down or not. So how do we know if you're going to be one of those? You know, it has to do with genetics, it has to do with your immunity, it has to do with what other risk factors the patient is experiencing. And so we've all seen patients that have a lot of heavy debris in their mouth, but they don't have any perio. And then we've also seen somebody that looks like they have a very clean, healthy mouth, and you start using the perio probe and you find that they have deep pockets. So I always think of your immune system as like a battery, and the more demand that you have on it, the quicker it fades away. So immunity really is the key to your health, and our body only has so many soldiers to fight our war. So if you had COVID, recovering from surgery, have perio, we have all these challenges to our body. Our body is going to break down much quicker. So that's why it is such individualized, and we really need to look at our patients and our patients' health history and all of their challenges when we come up with their treatment plan. And as he showed us, there was the 5 high-risk bacteria, anaerobic bacteria, that really does drive the periodontal process. And again, 50% of heart attacks are triggered by oral pathogens. I mean, that's a staggering statistic to just sit on and think about. And as a complete health dental professional and practice, we are responsible for these 3 inflammatory processes under the root cause tree: obstructive sleep apnea, periodontal disease, and endodontic diseases. So that is our responsibility in the practice to help Dr. Goulder with his patients as well as our own. So we do test. How do you know if you have periodontal disease? How do you know how aggressive the disease is? How does your hygienist know what bacteria they're working with and how to treat them? I always think by treating periodontal disease and doing periodontal therapy without having saliva testing is like me doing dentistry without my loops. You really don't see the whole picture and you don't have the details. So yes, we do saliva testing. We currently are using the HR5 testing because it does have the increased sensitivity. And we do compare our testing. And like I said, antibiotics is quite controversial in our profession. I understand that we don't use it all the time, but if they are a heart attack and stroke prevention patient and they have a lot of comorbidities, we know that this bacteria can enter the bloodstream and actually trigger a heart attack. So 1 round for 10 days of antibiotics with other supplemental aids is going to protect our patient and reduce the pathogen load. And so yes, we know that different bacteria affects different organs, different systems. This is a great little graph that I had put together. We do know that some bacteria cross the placenta barrier and can cause preterm birth and stillborns. Some are triggered and associated with cardiovascular disease. Some are with cancer, diabetes, and actually joint replacement. So we do use this saliva test and looking at our patient's genetic makeup and their health history to help with how aggressive we need to be with their treatment. And speaking of, dental clearance, I'm sure we've all had the form from an orthopedic surgeon or a cardiac surgeon asking for a dental clearance before they have their hip replacement or open heart surgery. And by signing this paper, you are telling the surgeon that there is no evidence that your mouth is putting you at risk. But if you're not saliva testing, how do you really know? You're signing a paper and telling somebody good luck and have good luck on their surgery, but you don't know that when you go in there and stir up that bacteria, that it's not going to land in the surgery site and cause a complication. And we do know that TD and TF are directly related to joints. So if I have a patient that is going to have an artificial joint, I'm specifically looking for that TD and TF. And so then there's the endodontic lesions. We know that most of them are asymptomatic, so we do use the 3D cone beam to rule out the possibility of some silent sources of infection and inflammation. We share the 3D cone beam between practices. If I see somebody with cardiovascular disease, or if Eric finds somebody that has a increased myeloperoxidase, he'll walk that patient down the hall and say, we need a 3D cone beam, we're looking for an endodontic lesion. So we do exchange patients. Like we said, we get every 3D cone beam read by a radiologist. And in one 3D cone beam, we could possibly be making referrals to ENTs, endodontists, periodontists, sleep physician, cardiologist. So even though we are seeing more than beyond our scope, it does give us an opportunity to collaborate with other specialists as well. And then, of course, sleep disorder breathing. You're hearing more and more of that in our profession, but it's a huge driver of inflammation, and it is one of the root causes of cardiovascular disease. We do have a Vatec machine that does have a schematic of airway, and so we do have the conversation. If we see it's restricted, it's a good conversation. We do know that this is when the patient is standing up in the machine and not laying down in bed sleeping. Obstructive sleep apnea affects 1 out of 5 adults that are undiagnosed. It is a undiagnosed medical condition that could possibly have a dental solution. If you are diagnosed with moderate obstructive sleep apnea, it can take 10 to 15 years off your life. And it's like smoking a pack of cigarettes a day in the cardiovascular system. So we put together this root cause airway tree. And as we've been learning more about airway, we're realizing that it really starts with development of the infant, and how if you look at the skulls from many centuries ago, how the skull was so much larger and much more rounded and had room for all 32 teeth. And now we have crowding and we barely have room for 28 teeth. And a lot of it is based on lack of breastfeeding and processed foods, baby foods and soft diet, to where we really haven't developed the tongue muscle to really manipulate food and reach the top of our arches to form the nice wide arch. We have to start looking for tongue ties that are keeping our tongues to the floor of the mouth. People that are not breathing through their nose because they have sinus issues or deviated septums. And so if we look at all this compromised airway situation, as we're going to start talking about, can lead to all these visible signs and symptoms that are on this tree. So kind of take a quick look at that. And ADHD and restless sleep, crowded cracked teeth, getting up 2 or 3 times to go to the bathroom, children bedwetting, mouth breathing, snoring. These are all signs of compromised airway. And you don't even have to know much about sleep, but if you can look at your patients as they're walking down the hall and you see this venous pooling, this purplish color under your patient's eyes, there's a good chance that they have obstructive sleep apnea. Or you can be looking at forward head posture when they have their head forward. Those people, when you look at them sideways, are usually gasping for air. But we as dental professionals are the best professions to identify patients for high risk OSA, because the hygienists are spending an hour of time usually with our patients, and you're looking for melon patty scores where you look and say, and you can hardly see their uvula or the back of their mouth. It's obliterated. You see scalloped tongue because there's not enough room. They have a large tongue with a narrow arch. They have reflux from heartburn, narrow palate, are all things that you could identify in the dental chair. We do a quick screening with a cotton roll across the arch from the lingual of 3 to 14. The good size arch, you should have a minimum of 38 to 40 millimeters between molar to molar. The average cotton roll, measure of the cotton rolls that you have at your office, is 37 millimeters. So you can see the difference from the arch on the left and the arch on the right of having a nice, well-rounded arch, a palate, and a place for the tongue. And the one on the right is a patient that you can only get about a half a roll, cotton roll in there, very high palate. We know that the tongue isn't reaching the roof of the mouth. And here you'd be looking for tongue ties in our younger kids. That they are usually the ones that can't breastfeed, and they are the ones that down the road are going to start having problems with obstructive sleep apnea. As we get older, we also, look for tongue tie because we know their tongue is not living where it should be. Dentists are not allowed to order sleep tests in Ohio or diagnose sleep apnea. So in our practice, Eric does do the ordering of the sleep test. This is Sleep Image. It's a ring that we use. Uses cardiac coupling. So we're looking at sympathetic and parasympathetic readings, but that we have the ability to be looking at what the age eye is and whether they have oxygen desat and what's their longest and average apneic. And it allows us to actually sit and talk with the patient, recommend that they have a head and neck exam to rule that out. Another thing that I know was discussed last month was cognitive decline, and how dentists are now able to be licensed in recode and precode to help rule out dementia and Alzheimer's. This was brought by Dale Bredesen, that is like the Bale Doneen Method, that he believes it is preventative preventable if caught in time. And so we realized that pathology for Alzheimer's actually can be present 20 years before you have any symptoms. And so the same thing that we do for arterial disease is very similar for Alzheimer's. We're looking for high-risk pathogens. We're removing amalgam safely. We're looking for sleep disorder breathing that's going to compromise the oxygen in our brains. And there's big studies that came out in 2019 that correlated PG with Alzheimer's. So again, we have the ability to do genetic testing at our office to see if they're high risk ApoE 3444, which puts them at higher risk, and also with the saliva tests. So we do work with a functional medicine doc that helps us with some of these 6 subtypes of Alzheimer's. Between Eric and I, we can take care of just about all of these subtypes: inflammation, sleep, diabetes, but we can't take care of the hormones, toxicities, gut health. And so we do network with a like-minded functional medicine doc as well. And so this is a way to learn more about getting educated. Is 18 hours of continuing ed for a dentist and 36 hours for medical. So we are 2 specialists that work together. We do have a flow chart on how we pass our patients back and forth, which I'm not going to get into because I want to show Tracy's case. As a general dentist, many of us don't have referral slips, but we do have referral slips to talk to our collaborating physicians so that they understand what our concerns are and how they can help us. But it truly is the hygiene team, and you really need to have a team that talks the same language and has the same culture. But we do, as dentists, need to support our hygienists and give them the proper education, the proper testing, and the tools so that they can perform at a higher level. So even though Complete Health Dentistry title comes with great rewards, it also has a lot of responsibility to it. But we really collaborating together for our patients. And so start today. And AASH is having a meeting in September, like I said, American Academy of Oral Systemic Health, where medical and dental come together, and Dale Bredesen is the keynote speaker for that. So I really want you to know, on a good day, we save a smile. On a great day, we save a life. I want to show you Tracy. As you know, Tracy had RA. He had high blood pressure. His mother was a diabetic. He had cardiovascular disease. He came in with 168 sites of bleeding and 68 sites of suppuration. The sad part of this whole story is that he had periodontal therapy 3 times in 18 months. We told him he needed 4.5-hour periodontal therapy. We do an hour per quadrant to disrupt the dangerous bacteria. He said, I'm not going to do it. And I found out he never had anesthetic when he was treated. And so if he had periodontal therapy 3 times in 18 months and he looked like this, I don't think Tracy really got the type of care he needed. He had 3 of the high-risk bacteria. TD and TF, as I said, is associated with joints, and he was very high with that. So we realized that, okay, he has high pathogens. We know he's full of inflammation with rheumatoid arthritis. Let's get a cone beam. We got a cone beam. We find out that he had 7 asymptomatic root canal lesions. We saw that he had airway challenges and that he had advanced bone loss in the lower anterior. He also had calcifications in the carotid artery. So now we know he has cardiovascular disease. So my hygienist, Eric, and I all sat down and we started talking his case, because we know we're going to be flushing this bacteria into a very high-risk patient. And so referred him. He had a CIMT. Yes, he has high risk. He has plaque. He had his blood test. HSCRP was 35. Normal is under 1. So it's the highest HSCRP. So I had a benefit of doing a blood test before doing any periodontal therapy. His myeloperoxidase, which we talked about from all that root canal lesion, was 609. He had his therapy. We put him in Perioprotect trays, which is a prescription with 1.7 hydrogen peroxide gel. He wore those 3 times a day. We put him on a oral probiotic. 2 weeks later, he said in his video, his hands were not hurting any longer. His 3-month periodontal chart, he had 4 bleeding sites. He had a 30% reduction in his saliva test. 4 months, he had totally gotten rid of his TD and TF, and then he kind of got off the wagon. He stopped using his trays. He was overdue, and guess what? Things start coming back. So this is not a one and done, but this is what I want to show you. He went from 35, and 2 weeks later, just with periodontal therapy, nothing else, his inflammation went down to 26, and then at 3 months, he went to 1.5. That's only dentistry. That is only periodontal therapy. Then he had his teeth, his lower anteriors extracted. His myeloperoxidase went from 609 from the root canals down to 324. So what I want you to see is saliva test and periodontal charting also is not necessarily going to follow. What I want you to see is Tracy's goals were accomplished. Go ahead. And he showed up at his repair appointment riding as Harley, as happy as could be. So now he's on his journey for his sleep. And so that's where he is now. He started seeing Eric. He's on his sleep. So we really have to start looking at our patients' health history, put their perio together, and see how are we treating our patients personally. A lot of good saliva tests out there. We got to be looking at the high-risk pathogens. Here's a perio chart with no bleeding, but look at all the pathogens. Here's something you would expect, a lot of bleeding sites, a lot of pathogens. Here's somebody with a lot of bleeding, you expect a mouthful of pathogens, and he only has FN. So what I say is do the best you can do until you know better. Then when you know better, do better. So we do have anybody that's on this call, if you're interested in having a CIMT at a reduced rate of $199, we are in Columbus, Ohio. You could scan the QR code. The dates will be put in the book tomorrow. If that's something of interest to you, or I'm going to put our contact information, you're welcome to call us with any questions.
And again, if you're far away from us and you want a CIMT, I would contact Cardio Risk in Utah. You can find their website, Cardio Risk Laboratories, and they can help you out with that. And also help you out with getting a ultrasonographer to come out to your practice and scan your patients for you. That's
great, Eric and Barb. Thank you so much for the comprehensive and entertaining and really information-packed presentation. And as far as a CIMT with Cardio Risk Labs, I will ask Virginia, who is responsible for sending out the post-event email, to include contact information to that group as well. And I just want to, in general, say that I hope everyone caught the medical-dental collaboration bug, because this is such a fulfilling and empowering experience to see how you can take a case and actually have the tools to diagnose and then actually do something about that diagnosis to treat people and bring them back to health. And as you promised, to actually save somebody's life. So thanks for what you do and for sharing it with everybody. And now, in the time remaining, let's get to some questions. First question is, are there other approaches to finding early asymptomatic arterial disease other than CIMT?
Well, certainly. I did mention the coronary calcium score, which is a CT scan, and we can see if you've got calcification in the arteries. It's not going to pick up the soft stuff, but it does pick up the calcification that says, yes, you're at increased risk. Those scores go anywhere from 0 to 10s to 50s to hundreds and thousands. The higher your score, the higher your risk for having an event. It's not a very good way to follow the disease process, but it is like I tell my patients, it's a light switch. It says, hey, you've got disease, or no, you probably don't. You can also do there's a computerized CT scan, which actually with contrast, you can actually image the arteries. It's getting more and more expensive. The nice thing about the CIMT scan is it's, you know, it's $200 or so, and we can see the plaque, we can tell the quality of the plaque, and we can follow the plaque over time and make sure everything's getting better.
Excellent. And here's a related question. Why is CIMT the artery of choice? Is it because it's a convenient location to analyze and that any arterial section serves as a valid representative sample of one's arterial condition?
Yeah, that's true. I mean, we can also look at the femoral arteries. The problem is once you get away, the carotids and the femorals are easy to get to. The carotids, you know, we can do with, you don't, when we're at a meeting or something, we're doing CIMT scans, you don't have to take off any clothes. We just, you know, the probe on your neck. The femoral we'll do in the office frequently when we're in a closed room, because even if the carotid's normal, the femoral may have plaque. Anywhere you can find plaque says you've got arterial disease. So if I do you know, Amy, she's got a bunch of great lines, as you probably know, but she says, you know, the Bale Doneen approach is, yeah, the cat in the gutter. The Bale Doneen approach is the opposite of our legal system, okay? Under Bale Doneen, you are considered guilty of having arterial disease until we prove you don't. So that means we check the carotids, and if we don't find anything there, we look in the femoral arteries. If we don't find anything there, we're going to do an ultrasound of your abdominal aorta and see if there's plaque there. Or look at your chest X-ray. Do we see, is there calcification in the aortic arch? Anywhere we can find evidence of arterial disease, you know, says that, yeah, you got a problem, even if we don't see anything in the CI in the carotids. And then we can use the carotids to follow things, making sure you're not developing plaque there, making sure that your arterial age, if it's increased, is shrinking down as we treat you, which means that everything is getting better if it's getting better in the carotids. So yeah, anywhere we can find disease, we'll take it.
So guilty until proven innocent beyond a reasonable doubt.
Right, exactly.
Good approach. Is there a test to know if you would be prone to SCAD?
SCAD, tell me what.
Yeah, I was hoping you knew what that stood for. Source cardiovascular, some sort of, I guess we don't know what it is, so I'm not sure we can answer it.
I'm sure it's a rhythm problem, but I can't think of what it is. I'm blanking.
That's fine. Well, you know what? We can provide the answer to that too if we can figure out
if they can email me, I would be happy to answer them.
Yeah, actually, whoever asked that question, if you can send another question clarifying what you mean by it, if you use the correct acronym or not, abbreviation. Meanwhile, let's move on. How does one's arteries safely calcify? I understand, you know, that there's that the intermediate condition is the more dangerous one, but you just have to hope that they solidify before they break free.
No, they'll count. Well, you know, when they calcify, what's going on is that we've gotten we're starting a thunderstorm here, so I hope you don't lose us.
Okay, me too.
When they calcify, that means you've gotten the inflammation out of the arterial wall, and that's just how your body's going to heal it. The addition, we often will have our patients take, you know, they have a low vitamin D, and that help drive arterial disease, and so we have them take a vitamin D supplement. We often have them take it with vitamin K2 or what's called MK7, and that actually will help the arteries heal, but without the calcification, but they'll still scar down. But the calcification doesn't bother me, as long as, you know, and if we treat people right, their coronary artery calcium score is going to go up invariably. And I don't care as long as I know that the inflammation's out of the arterial wall, because we're stabilizing the process.
Okay.
So
what is the core?
SCAD real quickly stands for, I just had it here, as a dissection of the artery causing a heart attack. Dissection means that the lining of the intima is tearing, and the blood flow can then get sort of burrow under the wall into the wall of the artery and close the artery from that way, not with a big clot. And that's not something that we're gonna pick up with a with a coronary calcium score or with a CIMT. If there's a tear in the lining, if it's actually going on, we can see it, but it's not going to be in the carotid. It's probably not going to be something we're going to pick up in the office, or if it is, we don't want them there.
Okay. And what is the correlation between carotid and cardiac vessel blockage?
So there's a really good correlation. It's, the whole thing tends to be a diffuse process. So if we see it, the arterial disease process tends to come on earliest in the coronaries and then down to the abdominal aorta, the iliofemoral system down to your legs, back up to the thoracic aorta, then finally the carotids. So typically, if you've got stuff in the carotids, you've also got it in your coronaries.
Okay, sort of an end stage almost.
Yeah.
Indicator. Well, we answered how does one actually deliver CIMT to patients. You can reach out to Cardio Risk Labs. Mm-hmm. Which saliva test is best and value for the cost?
I'm gonna let Barb answer that one.
We've been through quite a few. I started with oral DNA with the 11 bacteria, but we do so much post-testing that every time, after every periodontal therapy, so at 10, they're on 3-month recares, so they come back in 10 weeks for their post-test, so we know how well everybody did and what products that they need. It does get fairly costly. So HR5 came out with testing just the 5. And so they were about half the price of what oral DNA is. They turned it around in 48 hours versus about a week. And it is more sensitive for AA and PG. So there were many people that once we switched over to HR5, had PG, and they were like, I never had PG before, and it's that they are much more sensitive in their testing, so they could have had PG, but it just didn't show up. And being that PG is so correlated with cardiovascular disease and dementia, I felt that that was the best test for us. But there, I don't really care. It's like, use it, and it really helps your patients own their disease. It's something objective in testing that dentistry usually does not have, just like blood work for medicine. And it really does embrace the patients, and it gives them something to strive for.
It's a wonderful tool for them to visualize the issue and as you said, to track their progress and improvement. We only have time for one more question, and I'll end with this. Do you get pushback from your dental patients about oral pathogen testing?
We get that question a lot, and all I can say is when you discuss the benefits with the passion that we have in our soul, because we've been doing it for 10 years, they understand why it's a benefit. They pay out of pocket. They know it's in their best interest. And I bet you we're 98% when we present it of acceptance. We find a way for them to be able to do it. And like I said, with the lower cost, that makes it a little bit easier. But you just have to believe in it, and you have to have the passion. You're not just telling them they need it without really understanding it. So my hygienist is fabulous with that. And it's just so automatic for us. Like I said, I wouldn't do dentistry without my loops. So why would we want to do periodontal therapy without testing?
And that's perhaps the best note to end this on. Enthusiasm is contagious, and your team, when they buy in, with hope, they've had the scans and tests done on themselves, and they can tell a true story about themselves or someone they love or know, like Tracy. That's the way people will agree to this treatment, because they see the enthusiasm and you paint a picture that's so compelling for them. So that's fantastic. Yep. All right, everybody. In a few days, you will receive an email detailing how to apply to receive your 1.5 hours of CE credit. And I now want to invite you to mark your calendars for Thursday, August 24th, when my special guest will be Dr. John Highsmith, whose presentation is titled 5 Pearls for the 21st Century Practice. 0 receivables and 100% case satisfaction can be yours by Monday morning. Dr. Highsmith has owned a successful fee-for-service practice for almost 30 years and has taken over 250 hours of dental CE most of those years. He offers 5 pearls for clinical practice and management you can implement now. Attendees will learn how to actually have a negative accounts receivable balance, minimize patient dissatisfaction with veneers cases, maximize success with dental implant restorations, embrace the power of dental photography, and adopt a new patient focus instead of hygiene-driven practice. It all happens on Thursday, August 24th, so be sure to save the date and watch your inbox to register. Until then, this is Danny Bobrow thanking you for your commitment to practice perfection. Goodbye, everybody.
Good night.
Good night.